Today's speaker is Dr. Ken DeSantes, who is Clinical Director of the Pediatric Hematology and Oncology Program at the American Family Children's Hospital. 5 years ago, cancer immunotherapy was named the Scientific Breakthrough of the Year by Science magazine. Dr. DeSantes will provide an overview of some of the most exciting innovations in immune-based cancer therapies with a focus on pediatric cancer. We look forward to your presentation, Dr. DeSantes, and we have made a contribution to the Rotary International Polio Plus Fund as a way to say thank you for presenting to us. As a reminder, if questions allow, please wait for one of the audience microphones.
Thank you, President Donna. I'd like to thank everyone in the Rotary Club for having me speak with you today and share with you some of the really exciting research that's going on in the Children's Hospital to treat children with cancer. I'll apologize in advance. I'm sort of in the midst of a bad cold, so I'll do my best to try not to infect your podium here. Okay, so childhood cancer, fortunately, is not a very common illness. In fact, there are only 1 to 2 cases per year per 10,000 children. But even so, it is the leading cause of disease-related death in the United States among children and adolescents. So it is an important medical problem. The incidence of childhood cancer has actually been increasing over the years, as shown in the blue incidence curve at the bottom of the slide. Now, when you think of cancer, you think of adult cancers like lung cancer and breast cancer and colon cancer. We don't really see those diseases in children. In fact, the most common cancer that we see in kids is a form of leukemia called acute lymphoblastic leukemia, or ALL. This is followed by brain tumors, and then the most common solid tumor of childhood occurring outside the brain is a disease called neuroblastoma. So much of my presentation today is going to be focused on those 2 diseases. So if you were to perform a bone marrow on a normal person, I don't know why you would do that, but if you did, you would see the panel shown on the left. You see a wide variety of sizes and shapes of cells in the bone marrow. This is very normal. If you were to perform a bone marrow on a child with leukemia, you would see what looks like the panel on the right, where you have this very abnormal, monotonous population of leukemic cells that are pushing out against the bone, causing pain, crowding out the normal blood-forming cells that live in the bone marrow, leading to low blood counts, anemia, bruising, bleeding, all of the common manifestations that you think of associated with acute leukemia. Now, the story of treatment of leukemia starts back in 1948, where Sidney Farber and the Boston team reported very exciting results. They were able to induce temporary remissions in children with acute leukemia by use of a single drug called aminopterin. Now, this was very exciting news back then. They weren't able to cure anybody, but for the first time, they were able to slow the progress of the disease. Since that time, there's really been steady progress in the treatment of leukemia. So what's shown here are Kaplan-Meier survival plots. Each color represents a different time period. So if you go to the most distant past, shown in green, and this is in the late 1960s, early 70s, we were able to cure a very small fraction of children with leukemia, perhaps only 10%. And since that time, there's been progress. So if you come to a more recent era, shown in the yellow curve on the top, you'll see that we're now able to cure about 80 to 85% of children who present with this disease, acute lymphoblastic leukemia. So that's the good news. The bad news is that the treatment comes with a price. It requires 6 to 8 months of very intensive chemotherapy. Children have to stay on treatment for 2 to 3 years, and that involves taking an oral chemotherapeutic agent once a day, coming to the clinic every month to get an IV chemotherapy infusion, and then injecting chemotherapy directly into the spine every 3 months. In addition, there's a lot of toxicity associated with the chemotherapy, hair loss, of course, but worse toxicities such as nerve damage. There's a risk of infertility. Some of these kids will develop heart failure later in life, and the chemotherapy itself can induce secondary cancers even. In addition, if we're able to cure 80 or 85% of children with leukemia, that still means that 15 or 20% of children are not cured. The disease comes back. So we have made a lot of progress, but we have to do better. Well, how can we do better? Well, I think it was already mentioned that in 2013, Science magazine named cancer immunotherapy as a scientific breakthrough of the year, not just in medicine, but of all of science. And we've been focused at the American Family Children's Hospital on the use of the immune system to treat cancer for the past 30 years. I like to think we were a bit ahead of the curve there. Now, there are many different components of the immune system that can be used to fight cancer. There are antibodies, which recognize molecules on the surface of the cancer cell, flag the cancer cell for destruction by the immune system. There are cells of the so-called innate immune system. The best example is the NK cell, which stands for natural killer cell. These cells recognized when normal tissue becomes stressed in some way. And tissue can become stressed because of infection or because of malignant transformation. And then the NK cell can kill the cancer cell. There are T cells, cells of the adaptive immune system. These cells have receptors that recognize structures on the surface of the cancer cell and enables them to kill the cancer cell. And they can also develop memory. So if they see the same cancer cell, even years later, they can recognize it and destroy it. And then the new kid on the block is something called checkpoint blockade. If you've watched any TV in the last 5 years, I guarantee you've seen a commercial for one of these drugs. And what this is that the tumor can develop defense mechanisms against the immune system. In other words, it can actually turn off the immune system that normally would be directed against that. These drugs block that reaction. So they basically take the brakes off the immune system and allow the immune system to do a better job killing the cancer. So we have clinical trials at the Children's Hospital that involve each of these different components of the immune system. I'm just going to share a few of them with you today. So the hottest, sexiest therapy right now, probably in all of cancer therapy, I would say, both adult and pediatrics, is called CAR therapy. I'm sure a lot of you have read about this in the paper or magazines. So CAR is an acronym. It stands for Chimeric Antigen Receptor T-cell therapy. And the way it works is shown on this slide here. So if you have a child, say, with leukemia, we can remove the white blood cells from the child through a process known as apheresis using a machine shown in the upper left corner of the slide. A portion of those white blood cells will be these T cells. Now, T cells have receptors, as I mentioned, that can recognize a structure on the surface of a cell. The receptor is the goalpost-shaped structure on the blue circle. So the T cell receptor, for example, might recognize influenza virus. So the T cell shown here will recognize any cell that has been infected with influenza virus and destroy that cell. We've developed the capability to insert DNA into the T cell, and the DNA codes for a gene that codes for a different receptor. And that receptor is now shown in red. And the receptor will recognize whatever we tell it to recognize. And in this case, we're telling the receptor to recognize something called CD19, which is that green box present on the surface of leukemia cells. So it turns out that the most common type of leukemia in childhood, B-cell ALL, all express this surface molecule, CD19. So then after the cells have been genetically modified, we reinfuse them back into the patient. And now the T cell can recognize that CD19 antigen on the surface of the leukemia cell. And what does it do when it recognizes the antigen? It makes multiple copies of itself. It undergoes a process called clonal expansion. And now you have a whole army of T cells, all of which are able to recognize the leukemia and destroy it. So we were fortunate to be one of 9 pediatric centers that were part of the first multi-center trial in the United States to utilize this therapy to treat children with relapsed leukemia. And as a result of that trial, this drug was recently approved by the FDA for the treatment of B-ALL. And we actually treated the first patient, I believe in the Midwest, but certainly in our area, just earlier this month with the post-FDA approval drug, which is known as Kymriah. There's a trial being planned right now in the Children's Oncology Group, which is a large consortium that treats children with cancer in this country, to utilize this therapy not just for relapse patients, but for children with newly diagnosed very high-risk leukemia. So I have no doubt that this process, these CAR T cells, are going to revolutionize the treatment of leukemia in both children and adult. And there are many of these types of CAR cells that are now being developed for other cancers. And this just shows the very first patient of ours who received this treatment getting a nice hug from Katie Couric. Okay, I'm going to change gears now and talk a little bit about neuroblastoma. So children with neuroblastoma can be divided into 3 different risk groups. What you can see from this Kaplan-Meier plot is that children with low risk or intermediate risk neuroblastoma have a pretty good prognosis. They do well. But children with high risk disease have a dismal prognosis, and we have to do better. So how can we do that? Well, immunotherapy. In this case, we're going to use an antibody. The antibody is called CH14.18. How does the antibody work? Well, the antibody has what's called a binding domain shown in black. I'm not sure how well that projects, but the black portion of the antibody molecule will recognize something on the surface of the neuroblastoma cell, which are the yellow triangles, called GD2. So it'll bind to GD2. The other end of the antibody, shown in green, is known as the FC portion of the antibody. The FC portion of the antibody can bind to any cell that has a receptor for it, an FC receptor, shown in red. So what the antibody does then is it forms a bridge between the cancer cell, in this case neuroblastoma cell, with the natural killer cell to keep them close together and allow the natural killer cell to kill the cancer. We call this process antibody-dependent cellular cytotoxicity, or ADCC. So there was a clinical trial conducted by the Children's Oncology Group where children with high-risk neuroblastoma were randomized to receive standard very intensive therapy or standard therapy plus immunotherapy with that antibody. And the trial was actually stopped early because an interim analysis showed that children who were randomized to receive the immunotherapy actually had a 20% better survival than patients in the standard arm. So once we knew that, it was no longer deemed ethical, of course, to randomize children anymore, and all kids were shifted over to the immunotherapy arm. Much of the laboratory research that led to this antibody being brought into the clinic, and actually is now FDA approved, was done by Dr. Paul Sandel, who is actually the director of research at the American Family Children's Hospital. Is there any way we can maybe make this therapy even better? Well, we're going to be opening a trial probably next month where we're going to use natural killer cells that have actually been grown and activated outside of the body in the laboratory and infuse them into patients along with a different antibody called HU 14.18 IL2. So how does that work? Well, I've already talked to you about the CH 14.18 antibody and that how it can bind to natural killer cells through its FC receptor. The HU 14.18 IL2 antibody can do the same thing. It has a FC component combined to an FC receptor, but it has another molecule attached to it, this interleukin-2 or IL2. So the IL2 can bind to cells that have IL2 receptors. It turns out that NK cells also have IL2 receptors. So now this antibody has 2 different pathways by which it can bridge the cancer cell with the immune system. But even better, IL2 is a potent stimulator of natural killer cells. So when the IL2 binds to its receptor, it actually activates the natural killer cell so it can do a better job in killing the cancer. So this is how the protocol works. We obtain white blood cells, in this case, from the child's parent. And we take those cells and we incubate them along with another cell line labeled here K562. That cell line's been genetically engineered to stimulate natural killer cells. So we mix those cells together in a bioreactor, and we end up with a large population of natural killer cells. But there are some other cells in there too that we don't really want. So we'll get rid of those cells through a machine shown in the bottom of the slide, which is a cell sorting machine, and we're left with a very highly purified population of natural killer cells, which can then be infused into children with relapsed neuroblastoma, along with that the antibody, the HU 14.18 IL2 antibody. So this is a first in-human study being conducted at the Children's Hospital. Will probably open in a month. This is one of the typical rooms in the Children's Hospital, but it's actually unique. And it's unique because of what you can't see, which is that the ceiling, the floor, and the walls are all lined with lead. And the reason for that, it allows us to administer something called I-131 MIBG therapy. So what is that? Well, MIBG can be labeled with large amounts of radioactive iodine. And the MIBG is a compound that is selectively taken up by certain tumors, including neuroblastoma. but it's not taken up by normal tissue. So you can inject this drug intravenously and deliver a large systemic dose of radiation to wherever the tumor is, but there's sparing of normal tissue because the normal tissue doesn't take up the MIBG. And the tumor is killed by direct uptake of the radioactive iodine with the MIBG, but also by something called the innocent bystander effect. And that's shown here. So let's say this is a neuroblastoma with each blue circle representing a tumor cell. Some of the tumor cells will take up the MIBG, shown by that radioactive symbol, and they will be killed because of it. But even cells that have not taken up the MIBG but are just nearby will also be killed because the I-131 is firing off these radioactive high-energy particles in all directions, and the other cells get caught in the crossfire and destroyed. So this is a very complex therapy to administer. It requires a team of experts. Oh, sorry, it's the wrong slide. A team of experts to really administer this therapy. And when we built the new children's hospital, we specifically designed this room so we'd be able to administer I-131 MIBG therapy. There are about 15, maybe up to 20 centers now in the country that can do this. This is the very first patient that we actually treated. So this is an MIBG scan of a 19-year-old man who had neuroblastoma, and this is his pre-treatment scan. So all of the black dots that you see represent metastatic disease to his skeletal system. So this is pre-treatment, and this is post-treatment. So it's better, but you can still see those black dots. So the therapy in and by itself is not curative. It slows the progress of the disease, it buys people time, it palliates symptoms, but in and by itself, this is not a curative therapy. So is there any way we can make this better? Well, we think there is. So we will be opening another trial, probably early this summer, that combines the MIBG therapy with a drug called nivolumab, which is one of those checkpoint inhibitors that I mentioned earlier, along with an antibody, the CH14.18, that can recognize neuroblastoma cells. So we're combining radiation therapy with immunotherapy. And we have some very strong preclinical laboratory data suggesting this combination is going to be very potent. Just a word about the checkpoint blockade, because again, you'll see commercials for these types of drugs all the time. So tumor cells can express molecules on their surface, as I mentioned, that turn off the immune system. So this tumor cell is expressing a molecule called PD-L1. And the immune cells, in this case a T cell shown in the slide, has a receptor for PD-L1, PD-1. So what happens is when the T cell engages its ligand on the tumor cell, it sends a negative signal to the T cell. It turns off the T cell. So the T cell can no longer attack and kill the cancer. But if you block PD-1 with a drug like nivolumab, or you block the ligand on the tumor cell with other drugs that have been developed, you prevent this interaction from ever taking place. The T cell never gets inhibited, and now it can go ahead and kill the cancer. So this just shows the schema of the clinical trial that we'll be opening. Patients get 2 doses of MIBG, followed by treatment with nivolumab, followed by treatment with the antibody. So I focused on leukemia and neuroblastoma, but what about other types of cancer? We see many, many different types of cancer in children. And when cancer recurs in adults or kids, it's really a very bad story. It's very hard to cure. Anything we can offer these kids with other types of cancer who have recurrent disease? Well, there are. So we're currently enrolling patients to a trial using a different antibody called MGA-271. And this antibody binds to tumor cells that express a molecule on their surface called B7H3. And it turns out that neuroblastoma cells express B7H3, but there are a wide variety of other cancers that we see in both kids and many adult cancers as well express B7H3. But you don't see expression of this molecule on normal tissue. So it's a really good target for immunotherapy. It turns out that expression of the tumor of B7H3 in high levels is a bad thing for the patient. So these Kaplan-Meier plots are from children with a specific type of bone cancer called osteogenic sarcoma. And what you'll see here is that those patients whose tumors show a very high level of B7H3 expression have much worse survival. that's shown in the green curve, compared to patients whose tumors don't express B7H3 at high levels, which is the blue curve. So it turns out that this B7H3, we think, functions like a checkpoint molecule. That is, it turns off the patient's immune response against the tumor. So this antibody, MGA271, has been genetically engineered to have increased binding to the Fc receptor on NK cells, so it can work through that mechanism I explained earlier of ADCC, but it can also function as a checkpoint blocker. So if you have an immune cell like a natural killer cell, and the NK cell binds to B7H3, that sends a negative signal to the immune cell and it turns it off so it can't kill the cancer. But if we block B7H3 on the surface of the tumor with this antibody, now the immune system is able to go ahead and destroy the tumor. And this just shows the schema of that clinical trial. Patients receive weekly infusions of the antibody for up to 2 years. This shows the other sites that are participating in that particular clinical trial, which collaboratively makes up the Pediatric Oncology Dream Team, which we're very proud to be a part of. Okay, and the very last clinical trial just mentioned today is using something called haploidentical BMT or transplant to treat children with both leukemia and solid tumors. So what is a haploidentical transplant? That simply means the parent, the donor and the patient are half matched in their tissue type with each other. So why, usually when you think of doing a transplant, you want things to be matched. You want the donor and the patient to be matched. Well, why choose a half-matched donor? The reason is that almost every child has at least one biologic parent and therefore will have a donor for this trial. Parents are always going to be half-matched with their child because they donate half of their genetic material to the child. But in this case, you can get into a very bad problem because there are cells in the immune system of the donor, especially T cells, that can recognize normal tissue in the patient as being foreign because they're only half matched and attack the normal tissue. And that's a very serious complication of transplant called graft versus host disease, or GVHD. So if you have a half-matched transplant, don't you have to get rid of those T cells in order to avoid life-threatening severe graft versus host disease? And the answer is yes, you do. But that causes a problem because these T cells that cause graft versus host disease can also fight the cancer. And if you take them out of the graft before giving them to the patient, then there's a much higher risk that the patient's cancer will come back after the transplant. So is there any way to prevent that from happening? And there is. We're very, very selective about which T cells are actually removed from the graft. And that's shown in this slide. So Dr. Mario Odo is one of our physician scientists, and he actually helped develop the technology that allows this to happen. So when you do a bone marrow transplant or a stem cell transplant, you're not really just transplanting stem cells. You have stem cells, which are shown in the star-shaped figures on the top of the slide, but you have many other cells, like T cells and natural killer cells, which are shown there too. T cells, however, come in two different flavors. There's something called alpha-beta T cells. It turns out that these T cells are the ones that cause graft versus host disease. So we've developed the technology to label the alpha-beta T cells selectively with immunomagnetic beads, and then we run the entire graft through a magnetic column. The alpha-beta T cells are pulled out of the stem cell product, and all the other cells can go through. So you're left with your stem cells, your natural killer cells, and another population of T cells called gamma delta T cells. Now, these gamma delta T cells are actually very potent fighters of cancer. They can do a really good job in eradicating tumor. So by retaining those cells in the graft, there's a much better chance that the patient will not relapse after the transplant. So we have a clinical trial that's up and running now using this technology to treat children with relapsed cancer. So I'm just going to end by presenting one case study to you just to kind of bring this all down to a more human level. So JH was diagnosed with high-risk neuroblastoma when he was 6 years old. This is actually my patient. He underwent all the standard treatment for neuroblastoma, which is high-dose chemotherapy, radiation, stem cell transplant, immunotherapy, and he achieved a complete remission, did really well. However, at age 11, the cancer came back. You can just imagine how devastated the family was to have this news. So we retreated him with some more chemotherapy and local radiation to the site where the cancer came back, but knew that wasn't going to be enough. That wasn't going to cure him. And we didn't have really anything else that we could offer at UW at the time. So we sent him to Memorial Sloan Kettering Cancer Center in New York, which is one of the premier cancer centers in the country, because they had an open clinical trial using a different antibody to treat children with neuroblastoma. So we headed to New York. He was there for about 4 months, got this antibody, did well with it, came back to Madison, and we repeated his scans, and the tumor had already grown back. So at this point, things were rather grave. So we decided to treat him with I-131 MIBG therapy, and then the family had to make a decision. Do they want to transition to hospice care, or do they want to try something very experimental? We had just opened that haploidentical transplant study that I had mentioned, and they elected, the child was feeling well, it was doing well, and they really didn't want to throw in the towel at that point, so they elected to participate in this transplant study. So he went through the transplant and actually did pretty well. At 3 months post-transplant, his tumor burden was significantly less. His MIBG scan looked much better. At 6 months post-transplant, he was actually in a complete remission. So he's the very first patient enrolled in that trial, and he's almost 2 years post-transplant now and remains in complete remission. Now, is he cured? I don't know. I think we need a little more time to make that determination, but I do know at the very least we've bought the child some good quality time, and we've given the family hope. And hope is a really important commodity in our field. And this just shows the patient and the family getting the transplant that we call day 0. So it takes a village to cure a child with cancer. This is part of our village. And I really thank you for your attention. I'd be happy to answer a few questions if you have them.
Hi, thanks for your presentation and more importantly for the tremendous work that you're doing. Question for you concerns the funding for the research that you're doing. Where has the funding primarily come from and what are the prospects going forward?
Yeah, thank you for that question. There's no question that one of the most components of all of this is funding because we can't do any research without financial support. So the funding comes from a number of different sources. We do have some NIH funding to do this work, but most of the funding comes either from smaller grants through private foundations such as the MAC Fund or Solving Kids Cancer Fund, Hyundai Hope on Wheels, and then a good part of the funding also comes from philanthropic support. People have donated to the Pediatric Cancer Research Campaign at the Children's Hospital.
Thank you for your presentation. To overgeneralize very broadly, my impression is that the cancers are primarily a Western developed country problem. Are you or is anyone doing as much work, careful scientific work like you're doing in treatment for prevention?
Thank you for that question. It's a great question. In pediatrics, it's very hard to prevent cancer because the genesis of cancer in children is very different than the genesis of cancer in adults. So with adults, we think that most cancers arise after a series of mutations occur over many years. And there that presents an opportunity to maybe intervene somewhere along the line. In pediatric cancers tend not to have very many mutations, but the mutation that does occur that leads to the cancer is a devastating event. So it's a little bit harder to develop a preventative strategy for children when the cancers develop very quickly compared to adults where there's more time to try to intervene before cancer ultimately occurs.
Dr. DeSantes, my name is Mary Donahue. I work for the Ronald McDonald House. And I really just want to make a comment. Those of us who work at the house, we don't know the names of HU 14.18 IL.
It's commercially approved, FDA approved. You can call it Unituxin now.
Okay, thank you. We all think you need a marketer, but we can talk about that later. The names we know are Jackson and Josie and Caleb, and we know those names. And I just really want to tell everybody in this room that we think that you and Dr. Sandell are heroes. So thank you.
Thank you. I appreciate that. It's very kind of you to say that.
And we're going to chip in to get you a marketer.
We appreciate that too. If anyone has other questions, I'm happy to stick around for a little bit and answer your questions. Thanks so much for your attention today.
Thank you, Dr. DeSantes. One thing you didn't say that I was hoping that you said is anything that St. Jude can do, this hospital can do it as well. So think of that when you're sending your donations to Memphis, Tennessee. Okay? Thank you. We are adjourned.